Hello and welcome everyone to today's webinar on mental health care. My name is Matt Shepard. I'll be handling the technical side of things today. CMA's real representative today is going to be Medicare Center for Medicare Advocacy Managing Policy Attorney Kata Kertesz. And we are very excited to be joined today by Didier Trinh, Interim National Director and Director of Policy and Advocacy at the Diverse Elders Coalition, and his colleague, Ocean Lee, the Programs and Communications Manager. We are also joined by Deb Steinberg, Senior Health Policy Attorney at the Legal Action Center. So you are in fabulous hands today. Before I pass things off to Kata to introduce things, let me talk a little bit about this system, the GoToWebinar system we're using here. Today's session might be familiar to a lot of folks at this point, but some reminders about audio. I hope that everyone is hearing all of this, because that means you use the information in the email you received after registering to successfully log in. And you've either dialed in by phone, you've got good quality working speakers or headphones, and either of those will be great for you. As you are all likely aware, in these times, audio and video quality are at the whim of your hardware and internet. Video is going to be what it will be, but if you do have an issue with audio for some reason, you can always dial in old school by telephone using the number provided on your confirmation email. That number also exists in the little control panel that you should see at the right of your screen. Excuse me. If you don't see that control panel, but you're hearing me, somehow you've dialed in just using the audio and will not be able to actually interact with us. So please do make sure that there's a control panel. And on that control panel, there will be some key features for today. On the left side of that panel, there's a little orange arrow that'll let you hide the panel so it's not in your way. There's a little square that'll let you watch the presentation in full screen view. And finally, there's a little picture of a hand. That's going to be used to indicate that you have a question or a comment. While our presenters are providing their information, we're going to keep all of our attendees muted. When we open it up for questions, comments, and discussion at the end, you can use that little hand icon to indicate you have something to contribute, and at that point, I can unmute you. Then, if there might still be audio issues, please note we do have a questions section of the control panel. You can type your questions into that at any time, and I will do my best to pass those on to our presenters. Now, before we pull Kata up, a little bit about the Center for Medicare Advocacy hosting today. They are a national nonprofit law organization working to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities. The center focuses on the needs of people with longer-term and chronic conditions, working with legal assistance, advocacy, education, analysis, policy initiatives, and litigation. And all of that advocacy is based on the experiences of real people who contact us every day. Thank you for that. And now we'll pull Kata Kertesz up for our formal introduction. Kata.
Hi, thank you, Matt. And thank you all so much for joining us today. We have an excellent panel here to discuss mental health care in crisis. We would like to express our appreciation for our registrants who responded to our registration question. We read each response, we share them with our panelists, and those comments inform our presentations as we aim to cover as many of the issues you raised as possible. Before turning the presentation over to our panel, I would like to take a few moments to frame the issue we are discussing today. At the Center for Medicare Advocacy, we have long focused on health equity and social determinants of health, grounding our policy proposals and advocacy in health equity. An anchor in our work is that quality healthcare for all is a component of social justice. The COVID-19 pandemic put into sharp focus the systemic racism in our healthcare system, inequity in access to healthcare, and unequal health outcomes. This led to intense focus on these disparities from a broad group of stakeholders. Congressional committees issued studies on health equity and proposed policy changes to curb existing inequities. News reports flooded our inboxes, alarmingly relaying the unequal share of Americans who contracted COVID-19 with disproportionate cases among populations of color, and the unequal burden of the illness, with rates of serious illness and death from COVID-19 also disproportionately affecting communities of color. In the years that have followed, however, fewer and fewer reports and studies have continued to focus on this issue. At the Center for Medicare Advocacy, we understand that it is critically important to continue this introspection into our healthcare system and not lose focus of the fact that disparate treatment and unequal health outcomes for minority groups persist. As we analyze policy proposals and make recommendations for improvements to health programs for all beneficiaries, we must keep this unfortunate reality as a guiding principle and examine data, reports, and policy proposals through a health equity lens. Just as we examine issues through this focus, we will also call your attention to health equity considerations as our panel discusses mental health and substance use disorder treatment today. In discussing health equity in Medicare, it is important to note Medicare's background as a powerful force for equity. In 1965, Medicare created an important financial and social change tool toward the integration of hospitals. As a federal program affecting every hospital in the country, Medicare offered immense financial leverage. Any hospital that wished to be reimbursed by Medicare for the usually uncompensated care for their oldest and sickest patients was suddenly subject to the Civil Rights Act. The administration used this leverage particularly effectively in opening the door to hospital privileges for Black physicians, in addition to it being a major tool in creating access to basic hospital and other healthcare services for Black citizens throughout the nation, particularly in southern states. Before the enactment of Medicare, only 50% of seniors had health insurance, and 35% lived in poverty. That was a time when even a minor illness or injury could bankrupt older Americans and their families. In 1972, Congress added coverage for people with long-term disabilities, recognizing that like older people, they were often unable to obtain health insurance. One of Medicare's key strengths, compared with most other types of health insurance, is that its benefits are defined. The Medicare law, regulations, and rules set out the minimum scope of benefits that the program must cover and outlines out-of-pocket costs, and those are the same for everyone in Medicare. Despite all of Medicare's successes, particularly in terms of improving health equity, we know that there is much more to do and that bias and disparities still exist. As we honor National Minority Mental Health Awareness Month in July, we would like to take the opportunity to highlight the lack of comprehensive mental health care available for older adults and those with disabilities. Medicare beneficiaries struggle to access mental health care and substance use disorder treatments with often devastating consequences. Our panelists will discuss the coverage in Medicare, as well as other types of insurance, and how this is a particular issue for minority populations. They will also discuss the factors that contribute to the mental health crisis in healthcare, with a focus on minority populations again. As many of you noted in your response to our registration question, the major obstacle to care included access to providers and limited provider networks. Many of you also flagged the high cost of treatment as an obstacle to care. We want to take note of just how many older adults are struggling financially to put this into context. A recent KFF report highlighted the financial needs and well-being of older adults, analyzing the latest data on poverty rates among the 58 million non-institutionalized adults aged 65 and older in the US overall. About 6 to 8 million adults aged 65 and older were living in poverty in 2022. Among adults aged 65 and older, the poverty rate was higher among people age 80 and older, women, people of color, and people in relatively poor health. The share of older Black, Hispanic, and American Indian or Alaska Native adults with incomes below poverty was more than double the share of older white adults. Between 2013 and 2022, the poverty rate among older adults remained relatively stable at around 10%. This background on how much older adults are struggling financially is critically important to consider when assessing policy proposals. We know that even costs deemed quote unquote modest in proposals are often actually cost prohibitive for many older adults. Our panelists will also discuss how Congress and the administration can address these gaps in coverage and care to improve treatment, health outcomes, and also lower costs of care. As many of you know, the Center for Medicare Advocacy hosts our annual National Voices of Medicare Summit and Senator Jay Rockefeller Lecture every spring. The summit, in its 12th year now, is a convening of advocates and leading experts to reflect on access to quality healthcare for all, the challenges and successes of Medicare, and what we can do moving forward for older people and people with disabilities. At the summit in 2019, we were privileged to recognize the late Representative John Lewis from Georgia and his extraordinary leadership in advancing access to affordable health care and justice for all. He is often called one of the most courageous persons the civil rights movement ever produced. Representative Lewis dedicated his life to protecting human rights and securing civil liberties. Representative Lewis's inspirational remarks at that summit began with the discussion of how hospital segregation before Medicare cost people their lives. He said, quote, "I believe in my heart of hearts that quality, affordable healthcare is a right." Representative Lewis provided a call to action to advocates in attendance that year to always fight against injustice and not settle for the status quo, no matter how challenging the process may be. With Representative Lewis's words as our guiding principle, we will begin our panel discussion. I will first turn it over to Didier Trinh and Ocean Lei with the Diverse Elders Coalition, and next to Deb Steinberg at the Legal Action Center to speak about their organizations and their work on these critical issues. Didier?
Thanks so much, Kata. First, I really want to acknowledge and thank the team at Center for Medicare Advocacy for hosting and organizing this timely conversation. It's truly a pleasure to be joined today by Kata, Deb from Legal Action Center, and last but not least, my esteemed partner in crime, Ocean Lei. So just a little bit about the Diverse Elders Coalition. We were founded in 2010. And as a coalition, we advocate for policies and programs that improve aging in our communities as racially and ethnically diverse people, American Indians and Alaska Natives, and LGBTQ+ people. We are composed of 6 member organizations: the National Asian Pacific Center on Aging, or NAPCA, the National Caucus and Center on Black Aging, or NCBA, the National Hispanic Council on Aging, or NACOA, the National Indian Council on Aging, or NICOA, and SAGE, which stands for Advocacy and Services for LGBTQ+ Elders, and finally, the Southeast Asia Resource Action Center, or CRAC. All of our member organizations are experts in the distinctive needs of the racial, ethnic, political, and cultural communities they represent, and through their actions and their ongoing engagement in the Diverse Elders Coalition, they are viewed as trusted members in their communities who provide services and resources for diverse caregivers and their aging loved ones. And with that, I'm going to turn it over to Ocean.
Awesome. Thank you, Didier, for the warm introduction. And you know, if the audience, if you're looking at the handout, you know, we're on slide 2 right now, which shows our member organizations and a little bit more about the DEC. But just adding on to what Didier said, you know, yeah, the Diverse Elders Coalition, we're consisted of 6 member organizations, as Didier mentioned, representing 6 different distinct diverse communities. Historically, we have always focused on policy advocacy, but you know, recently we got a shift to focus on research to better understand the unique realities of our diverse constituents and see where we can better help. Now the DEC, yeah, so going back to that, you know, a lot of what you'll be hearing today from us in relation, the data points in relation to social isolation and loneliness will be directly from the research that we've done on diverse family caregivers and older adults. And yeah, so now what we're seeing in the DEC is a shift back into policy advocacy as we're better equipped to understand the issues and resolve some of the issues that our diverse communities face. And we also have DDA, you know, who's a stud and has been doing this for a while, and from my experience is he's just great at this. I don't know what else to say, especially at policy advocacy. But yeah, 6 organizations, DDA mentioned them as well. You can see them here on the slides, and our 6, the communities we serve are also here on the slide. Next slide, please. Good.
Sorry about that. That's that is on me. Um,
Not a problem, I'm
I
sure.
lost the slideshow behind all of my other windows.
Not a problem. Not a problem. Yeah. So as we all know, social isolation and loneliness is a mental health crisis, particularly among older adults. However, in diverse communities, social isolation and loneliness can look different, as it stems from different issues such as racism, discrimination, language barriers, and socioeconomic factors, especially when you think about immigrant communities or underserved communities, especially with socioeconomic factors. In fact, a recent study, which was also presented at the Alzheimer's Association International Conference, revealed an association between experience of racism and discrimination and increased cognitive decline. The study included African American, Hispanic, and Asian communities, and so I would like to say that this study is all encompassing, but as for now, this association is true for African American, Black, Hispanic communities, and Asian American communities. Yeah, and so in diverse communities, you're seeing that the reasons for social isolation and loneliness, such as racism and discrimination, may lead to more negative health outcomes, increasing the risk for more serious conditions such as Alzheimer's disease and related dementias, further emphasizing the need to resolve the mental health crisis that we're seeing, not only for older adults, but particularly for diverse older adults as well. Moving on, diverse older adults may also experience increased social isolation and loneliness because of cultural and language barriers, as you see here on the slide. These barriers may deter diverse individuals from utilizing formal services and reaching out to the community, as they don't understand the language or have difficulty because of their culture. And in fact, in our research, we, as the bullet point you see there, we found a significant association between cultural task difficulties and mental health strain and depression. And in our study, we defined cultural tasks as translating at the doctor's office, translating documents at home, or dealing with immigration papers. And so really issues that are faced by limited English proficient older adults and their caregivers. And we're seeing that the more difficulty they report with such tasks, mainly around language barriers, you're seeing a higher incidence of mental health strain and depression, which again, leads to these negative health outcomes that we talked about earlier. Another reason for social isolation and loneliness is discrimination and racism, which also has other implications as well. As we all know, when someone is discriminated against or someone is deals with racism, there's stigma that occurs, right? They feel stigmatized, and that may deter them from using resources again. In our study, more than 70% of individuals were deterred from utilizing formal health services because of the way they were treated. And so not only are our communities or our diverse communities dealing with social isolation and loneliness and depression, they aren't reaching out for help because they're deterred based on their experiences. On here, we talked about 55% of Black adults express concern about being treated unfairly. These numbers are comparable when you look at other diverse communities as well. Yeah. Lastly, diverse communities are dealing with health disparities and socioeconomic factors that make it difficult for them to access healthcare resources. Along with the high cost challenges they deal with, the communities of our diverse older adults are often underserved. This means there's a lack of community resources such as senior centers, cultural centers, public health offices, education centers, you name it. But the important part here is this, especially when it comes to education centers, is it increases the risk for substance use disorder, which we see particularly among our African American and Black communities and Hispanic communities. This has been supported by numerous studies that show a correlation between lower educational attainment and higher rates of substance use and addiction. And so it's very important that we serve our communities to make up for this lack of education, so that we resolve some of these issues that we see, especially when it comes to worsened health outcomes, such as increasing the risk for Alzheimer's disease related dementias and substance use disorder. And as we know, there's a significant association between substance use disorder and social isolation and loneliness. And so, yeah, and it's important to note that this relationship or this association between substance use disorder and loneliness is both complex, as we talked about. There's multiple factors, socioeconomic factors, and bidirectional, meaning that one can lead to the other, or one can come before the other. Someone could feel the stigma of using substances to deal with their anxiety or depression and not get help, and now be dealing with social isolation and loneliness, or vice versa. They're they're socially isolated and they're lonely, which may lead to substance use disorder. And that's what we mean by bi-directional relationship. And one thing to note, that numerous studies have supported this association, and it's a significant association. I could get into like the research terms, but it's a significant association, meaning that it's not by chance that this is occurring. So in a nutshell, the mental health crisis in diverse community is bleak and disheartening. I'm sorry for smiling, but it's true. Kata talked about what we've seen during the pandemic when it came to social isolation and loneliness, and from our experience and from our research, it's only been exacerbated not only during the pandemic but also after the pandemic, or now. And so, yeah, our communities are lonelier than ever. And like we talked about, this opens the door for much worse conditions, such as substance use disorders and Alzheimer's and related dementias, as we talked about. So, this is something that's on top of mind for the Diverse Elders Coalition. And we are honored to be here to talk about some of these issues with you today. Next, Didier will go over some key policies that you can help advocate for to resolve some of these issues, not only in diverse communities, but older adults communities as a whole.
Thanks so much, Ocean, for that great sort of zoom out of all the factors that go into creating this mental health crisis for diverse communities. Not surprisingly, much of the research that Ocean just highlighted did help lay the foundation for the DEC's work in the policy and advocacy arena. In fact, earlier this year, we at DEC released a set of high-level policy priorities to help focus policymakers' attention on the needs of diverse older adults and their caregivers. I'd like to take just a few minutes to give a quick overview of the core areas that we have been advocating for as a coalition, and we'll be sure to share them with you as well. So the priorities are focused on four main pillars. The first is around equitable access, looking to ensure that all federally funded programs include person-centered, trauma-informed and culturally appropriate and accessible services to reduce the disparities in aging services for diverse older adults. And when we talk about what accessibility means, we want to make sure that it takes into account the conditions where people live that also contribute to this range of disparities and inequities, such as the social determinants of health that Ocean mentioned earlier. Within the equitable access pillar, we're also calling for expanded language access by enabling older adults with limited English proficiency or LEP to navigate and hopefully receive the quality language assistance that they need across Social Security, Medicare, and Medicaid at the federal level. We also want to see the digital divide closed for diverse older adults by bolstering programs that offer access to broadband and also provide skills training so that they can become more digitally literate. And then finally, continuing to strengthen anti-discrimination protections in all federal programs around race, ethnicity, tribal affiliation, language, disability, age, sex, sexual orientation, gender identity, and immigration status, and make sure that we are looking at discrimination through an intersectional lens. The second pillar is investing more in home and community-based services. And we want to see, again, greater access to HCBS by creating federal standards for how we measure what access looks like and where the gaps are. Our third pillar is around supporting diverse family caregivers, in particular ensuring that eligibility criteria for programs and services offer an inclusive definition of family that goes beyond those who are just related by blood. Also providing universal, comprehensive paid family and medical leave to family caregivers, something that has been sort of a major effort over the last few years as we are sadly the lone remaining industrialized nation that does not guarantee paid leave. And then our final pillar is around data, specifically collecting, disaggregating, and reporting quality data on our communities. And we would like to see the federal government design and implement a demographic data collection standardization requirement so that we can better understand how all federal programs along the continuum of care are serving individuals, in particular those who are most marginalized and LEP older adults. So that gives you sort of a, like I said earlier, high level view into our broader advocacy work. For the purposes of our conversation today, I did also want to highlight where Congress is leaning in on the mental health crisis. First, by pointing out that there are a couple of bipartisan groups in the House and Senate that have mental health as their primary agenda. And on the House side, it's the Congressional Mental Health Caucus, which is co-chaired by Representatives Grace Napolitano of California, Don Beyer of Virginia, and Andrea Salinas of Oregon. It now has over 100 members of Congress. And as I mentioned earlier, they're focused on elevating mental health issues as a national priority. And they've been very engaged in ensuring that funding to support mental health programs is increased. More recently, on the Senate side, the Mental Health Caucus was launched last fall, which I think is evidence that mental health issues are beginning to really catch the attention of lawmakers. The Senate Mental Health Caucus is also bipartisan and was founded by Senators Alex Padilla of California, Tom Tillis of North Carolina, Tina Smith of Minnesota, and Joni Ernst of Iowa. And they too are aiming to improve prevention and early intervention efforts, expand the mental health professional workforce, as well as increase access to evidence-based mental health treatment for all Americans. So I think these caucuses provide a great avenue for educating other members of Congress on Capitol Hill and to engage them in legislation that we would like to see considered and hopefully enacted. So you'll see on the next slide the various bills that are currently pending in Congress. The first is the Pursuing Equity in Mental Health Act, which is important because it would require the Department of Health and Human Services, or HHS, to implement a strategy in consultation with advocacy groups and behavioral health organizations to reduce stigma associated with mental health conditions and substance abuse disorder among racial and ethnic minorities. The second piece of legislation that you'll see is the Stop Mental Health Stigma in Our Communities Act, which would require the Substance Abuse and Mental Health Services Administration, or SAMHSA, to also develop and implement an education strategy to reduce stigma, in particular among Asian American, Native Hawaiian, Pacific Islander populations. I think what's notable about the strategy that this legislation calls for is that it would advocate for increasing AA and HPI representation in the behavioral and mental health workforce, which I'm sure is an issue we'll be touching on during the course of today's discussion. With respect to AA and HPI communities, I did also want to highlight that in response to the COVID-19 pandemic, as well as rising anti-Asian hate, both since the beginning of the pandemic and frankly still ongoing, the Biden-Harris administration hosted its first ever mental health summit a year ago this month that really aims to improve equity and access to behavioral health care for AA and HPI communities. And that also dovetailed with HHS's Office of Civil Rights, or OCR, last year releasing its language access annual progress report, which created a new language access coordinator position, along with a centralized language access center. I think this is a really important development to highlight the need for more information, materials, and services to be provided in multiple languages. Also, at CMS, the Center for Medicare and Medicaid Services, they expanded culturally appropriate and understandable healthcare information for AA and HPI communities. They, for the first time, implemented a required cultural competency training for marketplace agents for the 2023 plan year, and also released the Medicare and You handbook for the first time in Chinese, Korean, and Vietnamese, which again is is just hopefully the beginning, so that we can have more languages available in providing this information. And then lastly, I wanted to point out, again, on the administration side, that SAMHSA's National Survey on Drug Use and Health enabled data analysis separating Asian American and HPI communities to help create their first ever report that included results disaggregated by race and ethnicity. A couple more bills I did want to highlight. There's a bipartisan bill called the Mental Health Workforce and Language Access Act, which would require HHS to award grants to certain federally qualified health centers for recruiting and retaining mental health care providers who are fluent in a language other than English. And more recently, there were a couple of bills introduced in the last couple of months. One is the Advancing Culturally Competent and Equitable Supportive Services, more easily called the Access in Mental Health Act, which aims to expand and diversify the mental health workforce by providing funding for graduate programs in mental health fields at minority serving institutions, as well as the Community Mental Health Wellness Worker Training Act. Sorry, let me say that again. The Community Mental Wellness Worker Training Act, which is also a bipartisan bill that would create a federal grant program to allow certified community behavioral health clinics, mental health centers, hospitals to train community workers and sort of lay members to do behavioral health screenings and interventions. As many of you know, accessible and culturally appropriate behavioral health care services are lacking in about a quarter of the US population. And so the bill would specifically train and support local healthcare workers who have the cultural competency and context to best serve those in their communities. And I will stop there, but happy to share more information about these bills. And I will turn it over to Deb.
All right, thank you, Didier, and thank you, Ocean, and thanks, Ocean, for all the resources in the chat. Welcome, Deb Steinberg.
Hi, thank you so much, Didier and Ocean, and thank you, Center for Medicare Advocacy. My name is Deb Steinberg. My pronouns are she, her, and I am a senior health policy attorney with the Legal Action Center. And I'm thrilled to be here with you today talking about mental health and substance use disorder care for older adults. Next slide, please. The Legal Action Center is a nonprofit organization that uses legal and policy strategies to fight discrimination, build health equity, and restore opportunities for people with arrest and conviction records, substance use disorder and mental health conditions, and HIV and AIDS. Next slide, please. We envision a society that upholds the civil rights of all people, regardless of their history of involvement with the criminal legal system or their health conditions. So we work to end the punitive responses to health conditions like addiction, mental illness, and HIV or AIDS, and to create equitable access to affordable, comprehensive, and high-quality healthcare, including harm reduction. Furthermore, we do our part to dismantle the historic and persistent impact of systemic racism that has fueled mass incarceration and disparate community health systems that further perpetuate health inequities. Next slide, please. In New York State, we provide direct legal services and we work on impact litigation. Our work with people with lived experiences helps to inform our policy advocacy in New York and throughout the country, including federal advocacy in Washington, D.C. We also provide technical assistance and education on a range of topics to help more people understand their rights and self-advocate to enforce them. And we also work in coalition and collaboration with incredible partners across the country, including the Center for Medicare Advocacy and Diverse Elders Coalition, to learn from each other and help advocate for systemic change. Next slide, please. So I'd like to start now by talking to you about the prevalence of mental health and substance use disorders among older adults. Next slide. Almost 6 million adults ages 65 and older had a mental illness in 2022. If we expand that out to people ages 60 and older, the number jumps to almost 10 million. Older adult females are more likely to report having a mental health condition than males, and they are more than twice as likely to report having a serious mental illness. Almost 4 million adults ages 65 and older had a substance use disorder in 2022. And once more, if we expand that out to people 60 and older, the number jumps up to 7.1 million. Older adult males are more likely to report having a substance use disorder than females. The majority of these individuals have an alcohol use disorder, but the rate of drug use disorder, such as opioid use disorder, has been rising in recent years. Tragically, older adults are losing their lives at high rates to these conditions. Older adults have one of the highest rates of suicide, with adults ages 75 and older having the highest suicide rate of all age groups. The rate of drug overdose deaths among adults ages 65 and older has risen 400% over the past 2 decades, with Black men over the age of 65 almost 7 times more likely to die from a drug overdose than white men over the age of 65. The rate of overdose death is also disproportionately high among American Indian and Alaska Native individuals. Next slide, please. As with any chronic health condition, people need to be able to access treatment to get better. There are many different kinds of treatment for both mental health conditions and substance use disorders. It is not one size fits all. Even when looking at all of these types of treatment together, less than half of Medicare beneficiaries with a mental health condition receive treatment in a given year. Less than a quarter of Medicare beneficiaries with a substance use disorder receive treatment in a given year. One particular type of treatment for which we have some additional data is medications for opioid use disorder. These medications are approved by the FDA to help people with opioid use disorder manage their conditions, and they are often seen as the gold standard of care. However, there are significant disparities in who is able to access this treatment. Age disparities. We see that only about 1 in 10 Medicare beneficiaries ages 65 and older with an opioid use disorder receive these medications, which is about 3 times lower than Medicare beneficiaries under age 65 with an opioid use disorder. Racial disparities. White beneficiaries are more likely to receive medications for opioid use disorder than Black, Hispanic, and Asian Pacific Islander beneficiaries. Another notable racial difference is the type of medication that people receive. White beneficiaries are much more likely to get buprenorphine, for which they can receive a prescription from a range of provider types and then pick up the medication at a pharmacy. By contrast, Black and Hispanic beneficiaries are about equally likely to receive buprenorphine and methadone, the latter of which is only available at opioid treatment programs that participants must attend multiple days a week to get their medications. Opioid treatment programs also typically have much more stigma attached, as well as to methadone treatment. Finally, an interesting economic disparity. Medicare beneficiaries with financial assistance for their prescription drug benefits, the Part D low-income subsidy, were about 3 times more likely to receive medications for their opioid use disorder than those without this financial assistance. This finding suggests that the cost of treatment may be a barrier to care. Next slide, please. The data on this slide from an analysis conducted by RTI International using the National Survey on Drug Use and Health from 2015 to 2019 further supports that cost is often a barrier to substance use disorder treatment. In fact, financial barriers were the most commonly reported reason for Medicare beneficiaries not receiving treatment, a problem that was much more common among beneficiaries ages 65 and older, about 38%, than those under age 65, about 28%. This category of financial barriers includes when insurance does not cover the treatment that people need, which, as we'll discuss in a moment, has been a long-standing problem in Medicare. Next slide, please. I want to take a moment to note that these types of disparities are not unique to Medicare and older adults. We know that some of you are caregivers or you're worried about your children as well. About the same percentages of adults overall receive treatment as those ages 65 and older, about 50% for mental health and about 24% for substance use disorder. Asian, Black, and Hispanic adults were less likely to receive mental health treatment than multiracial or white adults. Racism in the healthcare system, internalized stigma, and cultural beliefs may contribute to some of these access disparities. And we know that insurance is also a big part of the problem, and it's not just Medicare. Among people ages 12 and older who did not receive substance use disorder treatment but thought they should get it, more than 1 in 3 identified they did not have coverage for substance use disorder treatment, More than 1 in 3 identified that health insurance would not pay enough of the cost of treatment, and almost half said they thought treatment would cost too much. One of the key drivers of this is the low rate of mental health and substance use disorder provider participation in insurance, which we see across Medicare, Medicaid, and private insurance. Especially in Medicare Advantage plans, Medicaid managed care plans, and commercial insurance, we see incredibly narrow networks of mental health and substance use disorder providers, which is where a very small number of providers who work in a given area are contracted with the plan to serve beneficiaries and actively billing. As a result, people have to go out of network to see mental health and substance use disorder providers far more often than they have to do when they see medical providers. Out-of-network providers are often harder to find because they won't be listed in the directory, which can delay someone getting the treatment they need. It also ends up costing people more, either because they end up paying for all of their care on their own, or because insurance reimburses less for these providers than they reimburse for the providers within the network. But this data is also how we know that while there is certainly a workforce shortage of mental health and substance use disorder providers, that alone does not explain why insurance plans have such inadequate networks. Even though these issues are not unique to Medicare, there are a few important differences. Stigma against people with substance use disorders and mental health conditions compound with racism, ageism, ableism, and other types of hate and discrimination. But there are civil protections like the Mental Health Parity and Addiction Equity Act that still do not apply to Medicare, even though they apply to these other types of insurance. More on that in a bit. There's also less oversight and accountability, particularly in Medicare Advantage plans than in private insurance or Medicaid managed care plans. And finally, Medicare is just less flexible. It's a federal program and most of the coverage rules are in law and regulation. Whereas for Medicaid and commercial insurance, there's a lot more room to make changes to meet regional needs or the needs of diverse populations. Sometimes this rigidity and structure is a good thing, but sometimes it can be detrimental, particularly for minority populations. Next slide, please. And next slide. So looking at Medicare's coverage of substance use disorder treatment, as I previewed earlier, Medicare has historically had very limited coverage for substance use disorder care. Only in the past few years have we seen meaningful coverage developments that are building out the continuum of care. In 2020, Medicare began to cover opioid treatment programs, which are a key community-based treatment option for people to receive their medications for opioid use disorder, as well as other therapeutic services. At the same time, the Centers for Medicare and Medicaid Services, or CMS, began building out coverage for office-based substance use disorder treatment too. Intensive outpatient programs were just added to Medicare as of January 1st of this year. This program can be delivered in hospital outpatient departments, community mental health centers, federally qualified health centers, and rural health clinics, as well as in opioid treatment programs for people with opioid use disorders. However, a lot of these services are actually delivered in other community-based substance use disorder treatment facilities. So unfortunately, especially for the majority of older adults with an alcohol use disorder, it may still be inaccessible. With the rollout of 988, the Suicide and Crisis Lifeline, there has been movement among advocates for greater coverage of mobile crisis teams and crisis stabilization and receiving services, so that if someone is experiencing a mental health crisis or calls 988 for help, they have wraparound services to provide further support if needed. Medicare started covering mobile crisis psychotherapy at the beginning of this year, and it is reimbursed at a higher rate than crisis psychotherapy in other settings. In addition to coverage of these new services, Medicare also expanded coverage to some new provider types in January. These include mental health counselors, addiction counselors, and marriage and family therapists. CMS has also been working within its statutory authority to remove barriers to mental health and substance use disorder services for Medicare beneficiaries. You can see a couple of those examples on this slide. It removed certain prior authorization requirements and streamlined others. It increased reimbursement rates for certain services, like the opioid treatment program benefit and psychotherapy services. As of this year, Medicare also now covers new benefits called community health integration and principal illness navigation, as well as social determinant of health assessments, which help to address the social determinants of health of Medicare beneficiaries. And these are designed to be delivered by peer support specialists, patient navigators, and community health workers. But these individuals cannot bill Medicare directly for their services. However, they can work under the supervision or in partnership with a provider who is authorized to bill Medicare. Additionally, CMS has been building out services to help providers and care teams manage mental health and substance use disorders, as well as options for integrating treatment of these conditions into more medical settings. Next slide, please. So all of that is amazing, but it still falls short of meeting people's needs. So we've put together 3 key recommendations that would improve access to substance use disorder treatment in Medicare. Next slide, please. The first recommendation is to cover the remaining treatment gaps. Along the substance use disorder treatment continuum, residential care is one of the remaining gaps. That is, people can get intensive outpatient and partial hospitalization, but if they need anything more intensive than structured day treatment, their only option is inpatient hospital care. But that may be more restrictive than what the patient actually requires, which means that they may not meet Medicare's coverage criteria for inpatient treatment. As such, they often have to wait until their condition becomes more acute before they can get treatment, and that's why the full continuum of care must be covered, and we are advocating for Medicare coverage of residential treatment, and legislation is actually going to be introduced to do that in the very near future. Additionally, although master's level addiction counselors are now covered, that does not meet the full range of needs, particularly in states that don't have a licensing option for this type of provider, and many drug and alcohol or addiction counselors do not have a master's degree. As a result of systemic racism in education, healthcare, and many other settings, a lot of minority populations are still underrepresented in higher education and graduate school programs. So expanding out Medicare coverage to non-master's level clinicians would also help increase access to more Black and Brown providers who can offer more culturally and linguistically effective care. Another barrier is that community-based substance use disorder treatment facilities other than opioid treatment programs are not covered. This means that many of the services that are actually covered under Medicare are not meaningfully available, particularly for lower income beneficiaries where this may be their only local treatment option. I mentioned before that mobile crisis psychotherapy is now covered, but that does not include all types of providers, and it does not allow for a team-based approach to going out into the community and responding to mental health and substance use disorder crises. So we would like to see mobile crisis teams covered to help reduce interactions with law enforcement, as such encounters with the police have disproportionately harmful and punitive consequences for people with substance use disorder and mental health, particularly for Black and Brown individuals. Finally, I wish I had time to wax poetic about harm reduction, but it is absolutely critical that harm reduction strategies be better integrated into our healthcare system, including Medicare. Next slide, please. Our second recommendation involves removing some of the other barriers to treatment. We need to increase the reimbursement rates because mental health and substance use disorder counselors covered under Medicare are still reimbursed at lower rates than other providers. As you saw from data earlier, financial barriers continue to prevent people from accessing the care they need, even when they have insurance. So we need to continue eliminating cost sharing whenever practical. Similarly, we need to continue to remove utilization management practices like prior authorizations that only serve to delay and deter access to treatment. Research has shown that removing these barriers does actually increase access to care and reduces hospital and emergency department visits. In an effort to ensure that people can get access to the providers they need, we want to see stronger standards for Medicare plans to maintain adequate networks of substance use disorder providers. This would ensure that plans have to have substance use disorder providers and treatment facilities within a reasonable time and distance for all enrollees, including populations that have been historically underserved. Finally, the social determinants of health services are exciting, but they have some limitations, so we want to see those services built out. Next slide, please. Last, we need to extend anti-discrimination protections to Medicare. The Mental Health Parity and Addiction Equity Act is a civil rights law that requires Medicaid and private insurance plans to provide coverage for mental health and substance use disorder benefits in a way that is comparable to how they provide coverage for medical and surgical benefits. Essentially, it prohibits plans from arbitrarily limiting the days of treatment that people can get, or the settings where people can access treatment, or what types of providers can deliver treatment. It prohibits disparate reimbursement rate setting and any other strategies plans use to make it harder for mental health and substance use disorder providers to join or stay in their networks. And it also prohibits plans from using more restrictive utilization management practices or tools to deny or restrict care for mental health and substance use disorder than they do for medical and surgical conditions. These may sound familiar because I've been talking about them over the past few minutes, and that's because right now, all of these things can and do happen in Medicare. So we must get Congress to apply the Parity Act to Medicare to eliminate this discrimination against people with mental health and substance use disorders. And I think the next slide are just my references. And with that, I hope you'll stay in touch, and I look forward to answering your questions.
Thank you,
All right,
Deb.
thank you very much, Deb. Oh, sorry, Kata.
Go ahead, Matt.
I just wanted to thank Deb very much for that fantastic presentation and ask Didier and Ocean if they wanted to hop back on for Q&A. We have a couple typed, one hand up, and I know that you wanted to address at least one of the questions we got pre-webinar. So
Yes.
we have our few minutes here. Let's start with that.
Okay, so this is a question for all of you. We know that having data to underscore what we know anecdotally can help make the case for policy proposals, but are there any gaps in data collection and reporting in mental health, substance use disorder needs or treatment that you think would be helpful to highlight? Specifically, any data regarding minority populations and mental health and substance use disorder, and how can we help you push for that data that would be helpful to make the case for these policy changes? Any of you can start off.
Yeah, I can start off, and I think well, to start, I think a lot of people can help by advocating for some of the policies that DDA talked about. I'm not a policy person, but I believe the second one or the third one talked about improving language access to help diverse communities. That's something that we see. There is a lot of other gaps that we see in data collection, and to be honest, that's why the Diverse Elders Coalition shifted from a policy advocacy sort of organizations to a research focused organizations, is because we saw these gaps in data, especially when it relates to our diverse communities around mental health, substance use disorder, treatment, healthcare access, et cetera, et cetera. There's a need for that research. There's organizations out there trying to do that sort of research right now, one of it being the All of Us Research Program, which our member organization and ourselves are a part of. It's called the All of Us Research Program, with the goal of collecting 1 million plus data samples from diverse individuals. But yeah, the gaps in data collections that we see are in access, language barriers, discrimination, and we also see a lack of trust in our communities, but we don't know the extent of that distrust fully. And so those are some areas, and to advocate and to help resolve some of those gaps in data collections, I would say refer to DDA's slide. There was one on there about language access with policy, so push for that. That's my answer.
Thank you, Ocean. I have a question for Deb. Are there any proposals in the recently released physician fee schedule proposed rule for 2025 that relate to mental health, substance use disorder, that we should take a look at for comments? And also, will LAC be commenting and sharing any kind of comments with others so that we can also amplify what you all are saying about this issue?
Yeah, thank you for the question. There were a number of proposals in the outpatient prospective payment system and physician fee schedule. We are really excited that CMS has proposed to remove part of the custody exclusion, which prevented people who were on probation or parole from accessing Medicare coverage, which has a very disproportionate impact because of policing and drug policies and criminalization of minority populations. So we're really excited to see this being limited. There are some new increased reimbursement rates proposed for annual alcohol and depression screenings, which will hopefully help better identify people who may need treatment. There are some new codes proposed for safety planning interventions for people who are suicidal or who are potentially overdosing, as well as post-discharge telephonic follow-up contacts intervention. So those will also hopefully help people who are in a crisis. There are a couple of comment requests that are also really important on, for example, additional settings of care that they might be able to cover, such as community-based substance use disorder treatment facilities, CCBHCs, crisis stabilization units, and a few other proposals around medications for opioid use disorder, as well as non-opioid pain management medications. So we will definitely be putting lengthy comments together. We're happy to circulate templates and would really like to have everyone else weighing in as well to show CMS that we need to all continue to work together to improve access to mental health and substance use disorder treatment.
Thank you so much, Deb. Matt, I don't know if we have time for one more question, if there's anything else in the queue that
Sure.
like a quick one.
Let's get crazy and try to take a live question here. Lynn, you are self-muted. If you click on your microphone one time, we should be able to hear you, so you can ask your question. There we go.
Hi, can you hear me?
Yes, indeed.
Fantastic. Oh my goodness, I didn't imagine I'd have this chance. Deb, I wrote it in the chat just in case, but I much prefer asking you myself. As a person in recovery, and I am a behavioral health policy specialist at the Pennsylvania Association of Area Agencies on Aging. And I was hired about 3 years ago to help the area agencies on aging access mental health and substance use disorder services for the folks we serve. And first, I just wanted to say thank you for the work you're doing. The gaps in Medicare, of which I became a Medicare recipient about 4 years ago, are unbelievable and mind-blowing to me. I've worked in the mental health and substance use disorder field for 30 years. I've never seen anything like it. Please share more information about the restrictions that exist for community-based substance use disorder treatment facilities and what we can do to change them.
Yeah, thank you so much for your question, and thank you for all of your work. Right now, as I mentioned, Medicare is not the most flexible program, so all of the settings where care can be delivered are written into statute. So there is just no coverage for community-based substance use disorder treatment facilities other than OTPs, or unless those facilities are attached to a hospital or another facility that is covered. So it just prevents those facilities from actually offering the benefits that are otherwise covered. The long-term solution would be to change this in statute. The short-term solution, where you can also get involved, is by commenting on the physician fee schedule, a proposed rule that just came out of CMS, where they asked specifically if they should be covering community-based substance use disorder treatment facilities. And there might not be a lot that they can do without statutory authority, but they have found ways to kind of wiggle around the edges. And so we're excited to try and work with them. And again, we'll be putting out template comments. So I'm happy to share those with you as well if you want to echo some of the research that we cite and other resources. Thank you so much.
Thanks very much. Thanks for the question, and thank you, Deb, for the answer. We're a little over time here. We have a couple questions in the queue. I could forward them to presenters after if they were interested in those. There's definitely a couple specific to each of you in there. So I won't make any promises, but I will try to get those to you. Appreciate everyone's patience today. Do our presenters have any last comments?
Yeah, sure, Matt. Just maybe a call to action for all of those who are joining today to remain engaged and vigilant. Encourage you to follow our respective organizations and the work we're doing in this area. But back home, meet with your elected officials. Encourage them to join the congressional caucuses that I mentioned earlier if they aren't already members, to sign on as co-sponsors to relevant bills. And in the process, give your unique perspective, share your personal story. This is all extremely critical in helping to influence legislation and get these gaps addressed.
I'll jump in quickly. Take care of yourselves, take care of your loved ones, ask for help when you need it. And remember that policy happens because people vote. So please vote and get out the vote to your organizations and your loved ones.
And I'm gonna just follow up with what Deb said, because she said what I want to say is, yeah, you know, the easy push is to check on the ones around you. You know, we talked about mental health today, social isolation, and loneliness, and one of the ways we can advocate for that, or to resolve that, is by ourselves, and to just check up on the ones around you and your loved ones. So that's it for me.
Thank you all
Fantastic.
so much. Thank
Yep,
you all so
great
much
note
for
to
that
end
wonderful
on.
presentation. Yep.
Thank you, Kata. Thank you, Deb. Thank you, Ocean and Didier. This was a fantastic afternoon, and we did record it, even with my little slide hiccup at the beginning. Apologies, those intro slides that were playing on my screen that you didn't see, fabulous. So check out the recording for those. We will have that posted as soon as it processes, and we'll send out links to everybody that registered today. Thank you all very much for joining us, and I will now end today's presentation.